Hi, my name is Kirk Hamilton, your host of the Staying Healthy Today show. This is a show where we bring you key experts in the fields of nutrition, prevention, integrative, and lifestyle medicine. And I do interviews with experts, and then sometimes I talk a little bit on my own, and then we review the data for the individual, society, and the world. And today, uh, our topic is, do patients with endometriosis have impaired intestinal permeability? And this will be the long explanation compared to healthy controls and patients with pelvic pain, but without endometriosis. And our guest today is Dr. Shanti Mohling, MD. She's a OBGYN surgeon. And she and her colleagues put together an article that just caught my attention really fast. It was Intestinal Permeability and Endometriosis, a pilot study. And it was in the Journal of Endometriosis and Uterine Disorders in September of 23. And well, first, welcome, Dr. Mohling. Thanks for being on the show today.
Thank you.
And
It's a pleasure. Thank you so much, Kirk.
and so the reason this means so much to me, this topic, it's interesting, is so I've been in integrative medicine since 1983. So I've been using food and supplements and lifestyle to try and change people's physiology so hopefully they don't get systemic disease or treat it. So, for example, if I told the first practice I worked in 1983 in Marine Del Rey, they took everybody on, put them on a vegetable puree. So they took them off all the normal food they ate. And I saw everything improve in that setting. I mean, from migraine headaches to inflammatory bowel disease or whatever. And so you would say that they reacted to a food. But when I looked at your work, as the movement went on, it wasn't just a food allergy. It was that we were doing something to the gut and the microbiome, and that came into the picture. And as you altered that, you got more sensitivity for foods or systemic disease could pop up. So what's so wonderful about your work is where someone would make a connection between chocolate and a headache, you might not make a connection between food and your intestines and the microbiome and tissue being grown outside of the organ where it came from in other parts of the body, like endometriosis. And that's what's so profound, because if people can understand that concept, then they understand that food and lifestyle can create systemic disease a lot, I think, more profoundly than just the food and you get a headache. So that's why I was excited. It's like 40 years I've been doing this, and this has been a part of this medicine. I use the same lab you did the lactulose mannitol test on. And to see it done in this form for something that's really a tough issue for people. So if I come up to somebody and say, well, you have endometriosis, and maybe we could try a little lifestyle first if it's not too bad, and I show them this makes perfect sense. So anyway, that's my long-winded introduction. So you're going to be talking now. So you just share, how'd you get, your background, and then how'd you get to where you are today?
Okay, well, I can't wait to dive into the meat of our conversation, but I'll quickly tell you my background. I grew up in Boulder, Colorado. I studied massage therapy back in the time you were first starting your practice in the early 80s. And mid 80s, really, I started doing that. And so I began my whole thought process about health studying massage and herbology at the Boulder College of Massage Therapy. So that informed the rest of the phases of my career. While I was there, I realized I wanted to do more, study more science and take it further. And I started going back to school to study science at night, and basically ended up having to almost do college a second time so that I could get all the prerequisites. And then I went to medical school, and then I kept going. So now, fast forward many, many years, and I am now not so much an OBGYN, having spent years delivering thousands of babies. I now am primarily a gynecologist focusing on surgical management, mostly surgical management of endometriosis. Okay, so I now live in Portland, Oregon, and that's kind of my niche. Now, to tell you a little bit about this study, I want to first bring to light an important concept that I want to make sure is really clear for you. Endometriosis and how it starts, the etiology of endometriosis, is not entirely understood. And I think a lot of us who think about alternative treatments for endometriosis think of retrograde menstruation, and then maybe like unhealthy peritoneal fluid, and then maybe more stickiness, and we get these endometrial lesions or endometriotic lesions. And those of us who do excision, which is becoming increasingly the gold standard for treatment, tend to believe that these people were born with this disease. So most of the people who have endometriosis first experience it even before their first period. Right around the time of menarche, they start to have stomach problems, stomach pains, pelvic pain, and many, many times their very first period is terrible. So it could be argued, and that's not the point of our thing today. And truthfully, I think a lot of it's embryologic and it's genetic, but I still believe that there is a huge component in how a person experiences their pain and how their body responds to these lesions by creating a very healthy physical human environment internally.
So can I ask a question? Because I plead ignorance on exactly understanding what endometriosis is. So endometriosis,
Perfect.
the inner lining of the uterus, somehow some of that tissue gets in the abdominal cavity. I'm drawing a little circle.
Great. Okay. That's That's close. That's very good. And this is so important to clarify. Okay.
And it's mind-boggling how that would happen. I mean, to think about it, it's got to go through somewhere, right?
Well, listen. So endometriosis is endometrial-like tissue outside the uterus. And it's not exactly the same. So if you have a healthy person menstruating, minimal cramps, normal pregnancies, everything, the lining of their uterus is going to be healthier than the lining of someone who has endometriosis. And there will be biochemical differences. What happens, one theory that I tend to believe is that in embryologic development, as those primordial reproductive organ cells are migrating down to become the uterus and the tubes and the ovaries, some of those get stuck. And so I don't know if you're aware, but sometimes I take care of disease on the diaphragm and full thickness through the diaphragm. And so that is the pathway of these primordially developing reproductive structures. So we always think about endometriosis being in the pelvis. Maybe it comes retrograde menstruation, but 10%, 11% of people born female have endometriosis, and 90% at least have retrograde menstruation.
Okay. So last question on kind of the picture. The tissue that's in a healthy uterus, that endometrial lining, is not the same as what we find outside. It's similar, but it's not the same as what we find outside, which may have been there all along.
It behaves differently. So under the microscope, you're going to still see glands, stroma, and hemosiderin, blood. And it will look the same. However, when you do biochemical studies and do special staining and testing, the tissue is somewhat different and it behaves aggressively, very aggressively. Like sometimes I get into a pelvis and it's like, you can't even find the uterus. It's such a mess. So it can be super aggressive and it can be milder. And then moving on to my study, when I first started the data collection, I thought maybe it was retrograde menstruation and that unhealthy pelvic environment and intestinal permeability caused it. And I don't know. And I know that from my study, in half the patients who had endometriosis, they also had intestinal permeability. As you, Kirk, probably know, intestinal permeability is transient. You can have it and it can get better. You take all your NSAIDs, your alcohol, your inflammatory foods away, and someone's intestinal permeability can heal, right? It's not static, it's dynamic. But we still captured, in the patients willing to collect their urine for 6 hours, we still captured that half had it My controls did not, and my patients with pelvic pain and no endo did not. So this to me is very, very interesting. And it leads us down a pathway toward other things we know to be relevant. We don't know that they are causal. We just know they're associated, right? So we know that there is an association between intestinal permeability and endometriosis with pelvic pain. Don't know which one causes the other. We know endometriosis is an incredibly inflammatory condition. So
let me ask you this. So pain is inflammatory too. So
yeah, great point. Absolutely.
so if people had pain syndromes, but they didn't have endometriosis, so maybe it's a tissue that's more responsive to the inflammatory mediators that come through when you have big intestinal permeability. In other words, I can see that this is layers of inflammation. There's the pain, and then there's endometriosis because I don't know, more of these mediators and it stimulated them, prostaglandins, whatever we want to call them. How before we go too much farther, I'm going to go in your study, but how prevalent is endometriosis? How devastating is it to the average, patient? How common is it?
So 10% of the female population, patients born female, have endometriosis at least. And it can be mildly impactful with just severe dysmenorrhea, which is, I shouldn't say mild. I mean, it keeps kids out of school. But it can also be invasive into the intestine where you actually have a blockage of a fibrotic lesion and I have to remove part of an intestine. It can create severe infertility. You can have endometriosis invading the ovaries where you have huge ovarian cysts that are filled with blood chocolate substance. It is a debilitating condition. And the stages are variable, but even a stage 1 disease is going to be debilitating in terms of pain.
So how would a young patient know? I mean, all right, they have menstrual cramps. I mean, everybody's got menstrual cramps, right? So all right. If they come in here and they're complaining of something, it seems like a lot of people have menstrual cramps. So how many people that have menstrual cramps really have the beginnings of endometriosis? I guess that's what I'm saying. If somebody comes in there,
so that's okay. That's beautiful that you're asking that question. So painful cramps that keep you out of school are not normal. And most of the time there's something going on. And it could be that most of the people who come to see me have endometriosis by the time they come to me. And how we discern that, I can go into later, but some of them are already, they come to me, they are eating beautiful diets. They've fine-tuned what their food sensitivities are. They're eating as well as they can. They're trying to improve their microbiome. They're taking the right supplements. And they might help their pain somewhat, but not enough to make, generally speaking, not enough to make the lesions go away. What is possible, I believe, is that you can have endometriosis for whatever way that we get it. And along with endometriosis are going to be IBS type symptoms, bowel symptoms. There will be debilitating cramping pain with the period. There will be pain with sex because of the fibrotic lesions behind the cervix. There can be chest pain when it's on the diaphragm. There can be shoulder pain referred from the chest. There can be, I had a patient recently, I took endometriosis off of her diaphragm, and finally her chronic vomiting went away. And that's because of the relationship to the esophagus with the diaphragm. So it's a very debilitating, impactful disease. And absolutely, what I have learned at this point in my career is that as great as it is for me to surgically remove it, you have to also, once you've had this disease for a long time, everything spirals down. You've been on ibuprofen for years. Your gut is almost everyone's probably got intestinal permeability just from that. You have this secondary small intestinal bowel overgrowth often. Probably everyone's got intestinal permeability. And I want to talk more specifically about that. And so when we heal that, they can start to heal the gut aspects. Hippocrates says that all disease starts in the gut. I love this. We're still trying to figure this out. And this is like thousands of years ago, right? So these adjunctive things are incredibly important. We might need to do a surgery and remove an endometriotic cyst, because that's not going to go away with any amount of dietary change. But the person may still have pain in their gut and so forth. And so I do believe there's a weaving of how we take care of our bodies. Our lifestyle is incredibly important. As you and I know, same thing with aging. If I don't do everything I tell my patients to do, I can't like keep doing what I'm doing. I can't go to work every day. So it's incredibly important, and very similar. Similar things are at work, right? So, but I do want to talk a little bit more about the study and intestinal permeability.
So let's because I got so many questions. So go through the study the way that you want to go through it.
Yeah. Okay. Well, so I'm going to tell the story how I first got interested in it. And some of this will be probably ring true for you and your career path and what interests you. But I was learning, for various reasons, I was learning about celiac disease, and a Harvard pediatric gastroenterologist named Alessio Fasano, who is the person who discovered zonulin. And what zonulin is it's this molecule that's a gatekeeper, a gate junction holder of the cells of the small intestine. And what happens is with in celiac disease, you get too much gliadin, too much gluten, and you start to break down these barriers in between the cells, and you get this huge increase in zonulin. So zonulin is another way, if we have good testing for it, we may by now, not when I first started the test, to measure intestinal permeability. So once you get this big insult of gluten, you get a breakdown in the gap junctions, then big molecules can get through, bad bacteria can get through, antigens can get through, and you get this huge autoimmune flare. Okay.
I'm trying not to smile because I've given that sentence. I've said that sentence probably.
Oh, very good. Okay, so I'm preaching to the choir. Excellent.
No. I want you to say it because people believe you. They don't believe me. You believe you're the specialist. They believe you. So that'd be great.
I mean, but it's like beautiful. It's like been proven. It's like so impaired intestinal permeability is associated with celiac disease, with type 1 diabetes, with ankylosing spondylitis, with probably MS, with multiple autoimmune type diseases. So I said, okay, we don't really know. Is it going to be related to endometriosis? And it is associated. But with celiac disease, the intestinal permeability doesn't cause the disease, right? You've got a genetic predisposition, you've got an environmental situation, and then you get intestinal permeability, and then you get the flare, and you've got celiac disease. And so I don't know if there is a relationship with worsening states of endometriosis and impaired intestinal ability or not. All I know is there's an association between the two, and more. I'm not in an academic institution right now, but I hope there's more work on it, because what happens is when you have impaired intestinal permeability, you also have an impaired microbiome, and we know that that's associated with endometriosis too. And what happens when you have an impaired microbiome? Well, in my field, you know that you have an impaired estrobolome. What's that? The estrogen. microbiome, the estrogen microbiome. So
Right.
you have, okay, so 90% of the cells in our body are actually the bacteria in our gut, right? I mean, our gut is informing and is responsible for so many of the molecular functionings of our system, including estrogen levels. So certain bacteria have a beta glucuronidase that reconjugates estrogen metabolites when they hit the intestines. They get metabolized through the liver, get into the intestine. This bacteria says, "Hell no, we're gonna feed you right back to the body." Reconjugates them with their enzyme, and the total body estrogen levels go up. Probably more estrone than estradiol. We do know this is associated with breast cancer. So another reason to keep your microbiome happy, and I think what you were doing when you were giving these vegetable purees was you were, as you said, feeding the microbiome, but also people then were taking out those antigenic environmental impactors that probably were creating that intestinal permeability. So it's really interesting. That's really super interesting what you were doing in the 80s.
Well, it's followed all. I mean, if you follow the functional medicine world, there's always been the elimination diet, then there's a protein modified sparing fast. And now, one of the things I would love to see done with endometriosis patients is there's a concept called Prolon. It's the fasting mimicking diet by Walter Longo. He's a world renowned biochemist at USC, their longevity department. He uses it for longevity and cancer treatment. I mean, not cancer, supportive cancer treatment. And it puts you in a fasting state in this 5 day low calorie diet, very structured. He studied it for all the chronic illnesses. And I would be willing to bet, if you took a group of endometriosis patients and say once a month for 5 days, you go on this and you try and eat your basic standard good diet, that at the end of a year, you're going to see some profound changes because it stimulates autophagy, cellular cleanup, and regeneration of a lot of things. And this is very scientific. His name is Walter Longo. He wrote The Longevity Diet, and now his last book was it's got on myself, Fasting Cancer, because he fasts around cancer chemotherapy and enhances. But anyway, you're well, let me ask you this. Besides surgery, do you make any recommendations, or it's just you got to do the surgery and get them back to their primary care, or how do you I mean, like,
So
that's where we start off.
right now, I do my best to give as many ideas to the patients to really deepen their health. But it's not set up
What are
yet.
your ideas? But what are your ideas?
Right.
Tell me.
So
Tell me your
usually,
5 minute
yeah. So
speech to the patient as they run out the door.
I want them. I think one of the best ways to improve your microbiome is to eat 6 to 10 servings of fruits and vegetables a day. Right? Like, it's kind of just like your smoothie. If you are eating 6 to 10 servings of fruits and vegetables, your little gut bacteria are going to be happy, right? And so that translates to the body having all of its enzyme functions work well. When the gut is happy, we're happy, pretty much. So I try to get my patients off processed foods, right? As you might as well eat cardboard, and get them to do, if they're not I don't try to tell them to be vegetarian, although it's fine if they are. I think you can get plenty of plant-based protein. I think you need at least 4 good servings of protein a day, whether it's plant-based or fish, chicken, rare red meat, or a combination thereof daily. And as much as possible, limiting sugar and processed foods. And I really believe, especially when they're healing from surgery, that they have to do this. And you've done this for 50 years or so, 40, 30, since the 80s.
Good, 50 years. You just made me 70.
I calculate 30, it's 20, so 40 years. 1980 to 25 is 40 years.
83.
Okay, 40 years. Sorry. I was born in the 60s also. So Anyway, it's very hard to get people to stop sugar and processed food. And they're, they may think, oh, this is a processed veggie burger with this special processed gluten-free bun. It's still yards away from eating a whole food product.
How about one other thing on we're on par with our diet recommendations. Do you recommend dairy products or time off dairy products?
So actually, the endometriosis studies in patients who were raised with milk actually have less endo. So I think it depends if you have an allergy, how you tolerate it. I think moderate, just like a Mediterranean diet, minimal amount of dairy product is best. And the dairy products that you use ought to be cultured, like as in a good yogurt, kefir, high quality cheese, not a processed American cheese.
Okay, so we got a whole food diet, no sugar, more Mediterranean, tons of fruits and vegetables, lean animal food. Anything else?
Yeah, exactly. The occasional indulgence in some potato chips is okay. I do this too, but
How about alcohol? How about alcohol?
I think alcohol, hands down, increases impairs intestinal permeability. So I think if you're in a state of healing, you got to be no alcohol. I think I wish I drank no alcohol, but I drink a little alcohol. And coffee's a good antioxidant. It's okay to do a little, but not if it impairs your bladder function or your sleep.
So if I understand your practice, you get referrals from PCPs and other generalists.
I would say that I get local referrals a lot from physical therapists, interestingly, and yes, and then a lot of people come from out of state and some out of the country. They find me on social media.
Because you're just very good at your surgical technique and cleaning this up? Is that?
And also because I didn't finish what I tell them. I have a list of supplements also.
Tell me the
because I'm also really open-minded about the impact of diet and lifestyle on well-being with endo. You can't have 10, 15, 20 years of this debilitating disease where you can't move, you have no lifestyle, you can't exercise. Your body's going to be deconditioned. And so I really believe you can't just do a surgery and have someone be like, hee hee, yappy do, and my patients who do the best are eating well. They are already athletic. They've been powering through and trying to do their best. They rise above and do the best from surgery. So supplements that I recommend, and these are basic supplements that you probably recommend too, with the addition of a few others. So I think an essential omega-3 fatty acid, a high quality one, is important. I think vitamin D is important. Vitamin C is important.
Can I ask you what dose? Can I just on vitamin D? Do you have a level you're shooting for? Everybody, the basic traditional is greater than 30 micrograms per ml. Do you try and get up to 50?
I think 50 would be great. And I think for most people, a good quality 2,000 international units a day is reasonable. And some studies that I've looked at for endo have shown a benefit with 50,000 every 2 weeks or once a week, maybe that is.
I'm sorry, I interrupted your list there, but
that's okay.
Omega-3s, vitamin D,
vitamin C, 1,000.
Mm-hmm.
And then there's a couple other really important ones. And one of the most important ones lately that I'm hot on is N-acetylcysteine, also called NAC. And the dose for that is 500 milligrams a day.
All right, so you're stimulating your glutathione.
Exactly. And PEA, palmitoyl ethanolamide, 250 to 400 milligrams daily. Vitamin E, 800 international units daily. And another thing, so many of my patients are constipated, right? So what happens, this is another thing you'll find really interesting. So when you have these lesions in the body, they release a lot of inflammatory chemicals, cytokines and prostaglandins, as you mentioned. So that creates almost like a chemical ileus, a slowing down of the gut. The gut doesn't function well. So sometimes patients have a lesion on the bowel. It can even block the bowel, it grows into the bowel. But sometimes they just have an environment of nearby lesions and they still have constipation. So almost all my patients are on magnesium. And the in vogue one right now is magnesium glycinate, 400 a day at bedtime. So
Well, I can tell you that just on the magnesium issue, I interviewed 26 years ago a neurologist, and I just interviewed him again, and he was giving IV magnesium a gram, and his goal was to get everybody's magnesium, RBC magnesium, up to above 5 or more. You're deficient if you're in the 4s, and he could, pull out headaches and things like that. So magnesium is super. Yeah,
it is until it gives you elusive stools.
that's right. I have a question I didn't totally understand. There's one I wasn't familiar with. It was the PE ethanolamine. I missed that when you said it.
Palmitoyl ethanolamide. Palmitoyl ethanolamide. And I want to tell you more about that. So I got to just find my notes on it.
That one I haven't used as much. I'm not as familiar.
Right. It's sort of new for me to be recommending it. And yet there's a lot of data for not just endometriosis, but for, I'll have to maybe find it after a bit
Sure.
here. Oh, and also probiotics, I think, are valuable.
So do you have a favorite probiotic?
Right now I'm doing a protocol with one of my friends who works for Shackley. So I'm doing their vitamin protocol.
I got it. There's a million of them.
There are. And I can't find the PEA article right now. N-acetylcysteine has actually been shown in studies to shrink endometriotic cysts of the ovary. The only other way you can do this is with some really hefty hormonal manipulations. Mm-hmm. And I should also say that one of the things that is different about my approach with these patients is that so many doctors will say, well, you have endometriosis, it's too dangerous to operate, it's on the bowel and the ureter, and we can't take care of it. I remove it from those places. But they'll also say the only thing you can do is take birth control pills, or we can give you a DNRH analog such as Lupron or Orlissa or Myfimbri. And these medications put you into a state of menopause. They can cause irreversible bone loss, and they only temporarily shrink lesions. These come off the medication, which you're supposed to do in 6 months, and the lesions come back. So finding a better alternative that isn't so devastating in terms of its side effects has been one of the reasons that I really am such a believer in changing your lifestyle and really taking care of yourself in terms of what you put in your mouth.
I couldn't agree more. Before I forget,
again, I'm singing to the choir.
No. This is perfect. Listen, maybe it's little man primary care syndrome. But when a specialist says the things that you might say, and they're an expert in their field, and it's a unique thing that's devastating, people pay a little bit more attention. And but you're going to laugh at this. So in 1983, when I saw that happen in that clinic for 6 months, I also saw a physical therapist do massage therapy, and everybody walked out of the room like in La La Land. And I would be sitting in there an hour talking to people about their lifestyle, and they're they're not walking out like they're in La La Land. So I went back, became a massage therapist, literally from 1980. While I was a PA at nighttime, I spent probably 10 years doing it actively. So that I had to throw that in
Oh
before you
yeah,
left.
we share that. Yeah, it radically informs my practice still, having that history.
So is there anything else you want to add? I mean, I do you want to you've done a great job, a little bit more detail. You said, what are you going to do from this work? What is the next thought process that you want to prove or figure out, or are you just okay? We know
I,
that
I
intestinal
I may not. My next thing probably won't be a research project because I'm not set up in an institution where I can do that so easily. Other than that, I am working on a book that will really bridge these concepts of. I still believe you have to excise this disease, but if you don't take care of yourself, you're still going to have chronic pain.
right. Do you see the enhancement of this illness and frequency or severity with either relationship to the COVID infection or the COVID vaccine?
Not the vaccine. However, I've really asked myself that question, and there's not a lot in the literature about it. I do see people who were fine until the pandemic, and then they felt like they started to have worsening dysmenorrhea. It's not. I would say that it's a small percentage of the people I see who have pain and have had COVID. So I'm not sure.
So, well, let me answer this. Just in this time frame, is there more severe endometriosis and frequency now than there was 5 years ago? Let me answer that way. I'm asking
It,
it.
I think it seems like it.
Mhm.
5 years ago, maybe more than 20 years ago.
Okay.
But the advent of laparoscopy made it so we could see this disease instead of just cutting someone open and taking out their uterus for the disease. Now we can see it. We can, with laparoscopy, you can like, whoa, here it is. Let's remove this and let's remove that and get the disease out and save these organs. Like if you just remove a uterus, you're not going to cure the disease.
So just one last question in my mind. I just have to get this clear. I asked it, but it's not that tissue moves from inside the uterine lining and somehow gets out of the uterus and into the omentum area and the intestines and things like that.
Right.
It's that it was already there and it got in, but it's similar tissue that got inflamed for whatever reason. Is that more
Um,
correct?
Not so much that it got inflamed, but it's very sensitive to estrogen. So when a person goes through menarche and they start to have hormones, it starts to flourish. And these cells in someone who has endometriosis are more progesterone resistant also. So there's so many things about it, right? So I believe someone's born with these cells that are found in the body, and they flourish when they start to have menarche. But there may be other things that make it worse.
Or their microbiome is worse and they're recycling their estrogen.
Exactly. So they're having high levels of estrogen, really feeding this disease, right? Or honestly, what I'm going to also say is very, very controversial and not a usual gynecologist thing, but we're just giving every single teenager birth control pills. And combination birth control pills are 5 times physiologic estrogen levels. And I would say almost every one of my patients with endo has a history of being on birth control pills. And of course, many of them put on the pill because they had painful periods. So it does help decrease blood flow and decrease uterine cramps, but is it exacerbating this long-term problem with?
So now, yeah, one last question. If you were a practicing GYN and somebody just comes in for pelvic pain and you're not suspecting endometriosis, how would you treat pelvic pain like for a normal menstruating female that has pain during her menstrual cycle? I mean, it doesn't have.
So
Would you?
my first thing would be a full history. Number one, is there a family history of endometriosis, which is going to double the baseline risk of having it. So family history, how bad are these periods? Can you go to school? Can you function without ibuprofen? Is it taking you out of your lifestyle? It's going to help me taking you out of sports, taking you away from being with friends. Like some of these young people or middle-aged people who never got diagnosed don't have social lives because they feel like they can't go out. So hearing the details of that pelvic pain, not like I take an Advil and then pretty much 2 hours later, I feel great and I, go to soccer practice. Probably not endo. I have to stay home. I'm vomiting. I passed out. I had to go to the ER. They said nothing was wrong. Probably endo. Then I do a very careful exam. If they're virginal, sometimes they're going to let me do an exam. And what happens is when I do a careful exam, I can feel the uterosacral ligaments are thicker on someone who has endometriosis. I can sometimes feel nodularity. I can feel a retroverted uterus, which is more likely to be endometriosis. I can feel that there's maybe a frozen pelvis. Things don't move. That's endometriosis. A rectal exam is essential because a lot of that disease goes between in the pouch, in the posterior cul-de-sac, between the rectum and the vagina. You have to understand that. So I'll do that kind of exam. And then imaging is very often negative. It doesn't show peritoneal disease and even MRI. So if they are like going to the ER, they've been to the ER more than once for pain. Every period they have to come home and they're nauseated, they have diarrhea. I think you look in there with a scope. Everyone deserves that. If it's impacting their life that much.
So in your study then, to be fair, then what was the difference if you were just listening to the story of the people with pelvic pain and the people that had endometriosis? I mean, couldn't you tell was the pelvic pain the same? You see what I'm saying? I'm kind of confused because if you know it's
I had a smaller number of those patients, truthfully, but there are other things that can cause pelvic pain. And I've had patients who had pristine pelvises and they didn't have pelvic pain. So you then have to think about myofascial pain. You can have pelvic floor trigger points. You can have ovarian or uterine malformations, like a bicornuate uterus is going to be a little dysfunctional as it contracts. You have to think about infectious etiologies and also psychosocial. You have to also include that, but I try not to jump to psychiatric, like
heavy stuff.
Blame your pain on just because you're fighting with your mother. I sometimes psychosocial stuff turns out to be really almost the only thing you have. But I would say less than 5% of the patients I operate on don't have endo, but I've screened them.
You said one thing, I'm going to let you go, but you said one thing that caught my attention. You said physical therapists refer to you a lot.
Yeah.
Why is it that the physical therapist refers to you? Are they because somebody came to them with pelvic pain and they're trying to do,
they take care of patients with pelvic pain, and when they can't fix it, they know there's something else wrong. And most gynecologists don't actually really treat endometriosis. They might burn it and then it festers underneath and you still have neurologic pain. You still have neuropathic pain if you don't excise the disease. And so 90% of gynecologists, that's what they do. that plus birth control, antidepressant, and hormone blockers.
Great. All right. I'll let you go. Is there anything else you want to close with?
No, so thank you so much. Such an honor. And I love, we're very eye to eye about actually how we see how to be healthy.
Oh, when that title flew out, I had to grab that. I had to find this person to
Oh,
do this
thank you
interview
so
because intestinal permeability and endometriosis, it connects two worlds that I've been trying to connect for many years.
much. Yeah.
And when you do it in such a powerful way and a proven way, and plus I've used that test before, I've taken it myself. So anyway, thank you so much for coming on the show today. And I want to thank you, the audience, for listening to this edition of the Staying Healthy Today show.
Yeah.
And until next time, stay and be well.